Welcome to Convite House. This is the second in the series of Autopsy Academy talks, which deals with post-mortem toxicology, a subject which someone requested. So without further ado, let's begin by considering when we should take toxicology at autopsy. There are really 7 scenarios. The first and most obvious is if you are unable to offer a cause of death. In this case, you will need to take samples for toxicology and histology. In my experience, it is better to take both. Do not take one without the other if you don't have a cause of death. The second scenario is, and this rather unwieldy phrase is a stock phrase from autopsy reports, death is likely to be wholly or partially due to or hastened by drug or alcohol toxicity or overdose. You have to make the decision based on the death report, the clinical history, any other information you have, and the scenario in which the death occurred, the scene at which the body is found. Obvious pointers will be a history of drug abuse, the presence of drug paraphernalia at the scene, any witness statements that mention drug taking, or any circumstances that just are suspicious, like deaths in nightclubs and such like. This is where you have to use your judgment. You have to profile the deceased to decide whether it's worth taking samples. The reason we don't do toxicology on every case is because it takes time and it's expensive. The cost of toxicology is greater than the cost of the autopsy itself, and so for every coroner's case to have toxicology would be prohibitively expensive. This, however, means that the majority of cases will not be sampled. Amongst those will be some cases that would have turned out to be drug-related deaths. For example, many years ago I had a case that was an old lady, and I did tox solely because she was diabetic. She didn't have an obvious acute morphological cause of death, and I was worried about her diabetic control, but it turned out that she had taken an overdose of secobarbital, which is what you are given if you go to one of the assisted dying clinics in Europe. Other indications are the general appearance of the body. Do they look like somebody who might have been a drug user? One case was a man who had a tattoo that said, "I love drugs." Love was spelled L-U-V, and yes, he did die of a drug overdose. The third scenario is traumatic deaths and suicides. That is where suicide is not obviously due to ingestion of drugs. This is for the benefit of the inquest into an unnatural death, where one of the questions will be, was the person's action intentional? Were they acting under the influence of drugs or alcohol? And for accidental deaths, there may be the issue of whether they were in some way responsible for the accident. Were they intoxicated at the time? So in these cases, although toxicology doesn't directly determine the cause of death, it should always be taken if available. Fourthly, allegations of poisoning or drug abuse have been made. This is fairly obvious. However, they are increasing in frequency. If the allegation is such that someone is being accused of homicide, then it's clearly going to be a forensic case, it's going to be a special. But there are many other cases in which the death report will say that the family suspect that the person was using drugs, or that in a clinical setting they think that death was due to prescription drugs that were wrongly prescribed or inappropriately prescribed. This is a growth area. If someone dies in hospital, there are, in the post-Harold Shipman era, not infrequently allegations that someone in the hospital or someone from outside either intentionally or inadvertently gave an overdose of morphine or some other drug that shortened life. It does not matter if you think the claim is improbable or if you think it has no basis, no factual basis on which to rest. This will come up at the inquest, and in order for you to be able to refute the claim that death was hastened by drugs, you need to have an appropriate toxicology result. Fifthly, you suspect either ketoacidosis in poorly controlled diabetes or anaphylaxis. The history and the circumstances may be suggestive. Again, you may find that there's a claim made that the next of kin think that the death was related to an allergic or an anaphylactic response to drugs or some other substance. Even if you think this is improbable, and quite often the suspicious substance was given hours before the actual death, you will not be able to refute it unless you have the appropriate blood tests. And for anaphylaxis, it is mast cell tryptase that is analysed. It is notoriously labile, but as long as it isn't elevated, you can say there's no evidence of anaphylaxis. Number 6 is when you're contemplating a diagnosis of epilepsy or SUDEP, sudden unexpected death in epileptics. A negative toxicology report is required because these deaths are, unless they're witnessed, often diagnoses of exclusion. Someone is known to have epilepsy. They may have died of a seizure, but it wasn't witnessed. They may or may not helpfully bite their tongue and empty their bladder before death, but I wouldn't count on it. And for SUDEP, it's again a diagnosis of exclusion, so you have to have a negative toxicology result. Plus, in epileptics, there may well arise the question of whether their anticonvulsant dose was appropriate, whether they were on the right anticonvulsant, or whether they were taking the medications they were prescribed. So it's important to have a record of this, and when you fill in the toxicology form, tick the box for compliance with medication, put anticonvulsants, and name the anticonvulsants that they were supposed to be taking if you know what they were. Finally, if the coroner instructs you to take toxicology. For people who are inexperienced and for the avoidance of doubt, the coroner cannot instruct you to perform an autopsy, but the coroner can instruct you to carry out certain tests as part of the autopsy that you have agreed to do. And in some cases, some coroners will expressly say that they want you to take samples for toxicology. There you have it. You don't have to pay for it, and if it turns out to be negative, which it often does, you can feel very smug. What samples to take? The commonest sample is obviously blood, and it should come ideally from the femoral vein, although if you take it from the brachial vein, that will do. Blood from the heart, or even worse, cavity blood, is not suitable and will not yield reliable results. This is important. It is often not easy to get a good sample, or indeed any sample. In traumatic deaths, the blood has sometimes leaked away at the scene and so isn't in the body. In decomposed bodies, it's hard to get blood, and sometimes even in people who haven't died a traumatic death and haven't decomposed, it's still surprisingly difficult to get any blood out of the femoral vein. Some people, including some coroners, seem to be surprised about this, but it happens, and you will not always manage to get an adequate sample. Ideally, you should get about 10 millilitres, although 5 will do, and split that between a preserved sample, which goes in a little yellow tube, and an unpreserved sample, which just goes in a universal container. The preserved sample will yield a more reliable assay for substances that are labile, particularly alcohol, which is produced by fermentation after death. There are surprising differences. There was a study that showed differences in results in drug concentrations depending on whether you sample the left femoral vein or the right femoral vein. And although the response to that particular study may be get a life, it does make the point that toxicology is not as exact as people would wish it to be. Be careful not to get a contaminated sample. If the blood comes from the body cavity, it will be contaminated with stomach contents and all kinds of other things. It will usually be your technician who takes the sample. In some mortuaries, don't let them cheat, don't let them get a poor sample because it won't be reliable. Even milking the lower limb to get the blood out is said to alter drug concentrations, but there's often no alternative if one is to get a sample. Urine is easy to take provided there is urine in the bladder. Just put a needle through the bladder and withdraw the urine. Vitreous humour is one of the easiest samples as long as the body isn't decomposed. You can sample both eyes. If the body is decomposed, or for some reason you can't get any adequate samples of fluids, then liver is normally available. If people don't have a recognisable liver, then the hope of toxicology is probably gone. Stomach contents used to be popular, is much less popular now. The obvious drawback of stomach contents is that it shows what's in the stomach, not what was in the blood. It may be useful if you can identify tablet residue in the stomach contents, which you should always look for, but aren't sure what it is. The invention of the internet has helped considerably, because if you do find recognisable tablets, it's now fairly easy to search for them on the internet and work out what they were. But if you can't identify them, and there do seem to be a lot of tablets, then sending stomach contents is one way of ascertaining what was swallowed. Cavity fluid is a last resort, but is better than no sample at all. And finally, hair. Hair is a marker of chronic drug use, because obviously the toxicological analysis of hair doesn't reflect the situation at the time of death. It can be useful in scenarios where the family say the deceased never took drugs, except on this one occasion when some nefarious person administered drugs to them. So if you send some hair for testing, that can indicate whether or not there had been historic drug use in the weeks and months prior to death. You're supposed to pull the hair out, which for some reason always makes me wince, even though I've already cut out all the organs. But pulling people's hair out, I always find a little bit unsettling. And there's a little chart that you can get from the toxicologists that tell you where on the head you're supposed to pull the hair from in order to get the best results. Of these samples, only blood is a quantitative sample. All the others are qualitative, with a few exceptions. Some things can be measured in urine. Alcohol is fairly obviously one of them. But most drug concentrations can't be measured in urine, or at least the toxicologists won't measure them because they don't think they're reliable. Again, vitreous humour is particularly useful for glucose. Liver is always qualitative, as is cavity fluid. This means that the tradition of taking 2 or 3 different samples is probably not particularly useful, because the one you want is the blood, which will give you a quantitative result. Failing that, the other samples are far less helpful. So if you have an adequate blood sample, you're not adding a great deal by adding other samples. There are certain situations, particularly diabetes, which we will come on to, where you would like to see the results from urine and vitreous as well, and particularly glucose. The fluid of choice for glucose assay is vitreous humour. Completing the toxicology form. I'm often asked by people, what's the most frightening thing you've ever seen in a mortuary? And I always say the same thing: paperwork. There's so much of it, and it's so easy to get it wrong. Please try to fill in the form carefully. All your efforts will be undermined if you manage to mix up the samples, or if you don't give adequate information. And as a pathologist, you will probably be used to receiving samples for analysis. It's very frustrating if you don't get the information that you need to carry out your examination properly. It's very irritating if you don't have the information in order to perform the autopsy. So it's irritating for the toxicologist, and it's unproductive for you if you don't tell them exactly what you're looking for. So summarise the history and what you found. What you found will often be nothing, which is why you're doing the toxicology. Provide a list of medication. It obviously suffices just to send the death report if it's in there, or to send the GP's summary, particularly useful for epileptics. And write if there are any special requests. So if you're suspecting anaphylaxis, you ask for tryptase, which they'll tell you is unreliable, but you'd like it anyway. If it's a fire death and you're considering inhalation of the products of combustion, then carboxyhemoglobin. There's a long list of drugs that form part of a routine toxicological screen. This is the list from one lab in London. I often hold this up in court to show the range, the breadth of the screen that's performed. It doesn't include everything. So if you want something specific to be tested for, then you need to write it on the form. It also means that there are some undetectable drugs. Many of the so-called legal highs, they're illegal now, but they used to be legal. They used to be sold down in Camden and probably still are. But the composition of them is so unpredictable that it just isn't possible to screen for everything. And there are also some poisons. There have been a number of recent suicides using sodium nitrite, which is a substance used for curing meat, apparently, and which is obtainable in large quantities off the internet. It's often written on death reports as sodium nitrate because the majority of people haven't heard of sodium nitrite. If the death occurs in Birmingham, sodium nitrite's the same as sodium nitrite anyway. Ketoacidosis. This is perhaps the most complicated and confusing area, and what I would suggest is making a version of that table and keeping it around for reference, and if you're going to take an exam, memorizing it so that you can interpret any results correctly. In cases of suspected ketoacidosis, it's very helpful to have samples of blood, vitreous, and urine. In ketoacidosis, acetone will be elevated, as will beta-hydroxybutyrate. The toxicology report should tell you whether the degree of elevation is pathologically significant, because obviously many people, when they're dying, will become somewhat acidotic. That in itself isn't significant. It needs to be above a certain level, and the level should be stated on the report that you get. In diabetic ketoacidosis, the vitreous glucose concentration should be raised, as should the urine glucose concentration. This, of course, presupposes that you can manage to get all three samples, a hat trick of samples from the case. You're not going to get it in every case. Also, because glucose is broken down after death, the vitreous glucose is tending towards zero. And if the autopsy is delayed, which these days they pretty much all are, the days of people having an autopsy the day after they died are probably gone, at least for the time being. So a normal or low vitreous glucose does not rule out there having been hyperglycemia at the time of death. A raised vitreous glucose indicates that there was hyperglycemia at the time of death. In alcoholic ketoacidosis, beta-hydroxybutyrate's raised. The vitreous glucose again can be raised, or it could be normal or even low. The urine glucose concentration would typically be low. The distinction here with diabetes is that in the diabetic scenario, the person's diabetic, whereas in the alcoholic ketoacidosis scenario, they're either alcoholic or they're a binge drinker. They will, and this is important, typically not have an elevated level of alcohol, because these are the alcoholics who have laid off the drink. You do, of course, get people who are alcoholics and diabetic, so you can have fun trying to sort out what the cause of their ketoacidosis was. Then for completeness, you have hyperosmolar hyperglycemic non-ketotic syndrome, which is death due to hyperglycemia. So they should have raised glucose in vitreous and in the urine, but will not have ketones in the blood. So in deaths that you think are due to ketoacidosis, either from diabetes or alcohol, try to take the 3 samples, try to make an assessment. I don't do this in every case. Just because somebody is diabetic does not mean that I take all these samples every single time. If they have a plausible morphological cause of death, then I will go with that. And particularly in older patients, if their diabetic control wasn't very good, that doesn't substantially alter the cause of death, which will be something like ischemic heart disease with diabetes in part 2. This is much more germane for younger people who are relatively healthy and who have died unexpectedly. A little more on diabetes. Everyone knows about insulin murders. I think there's a book called The Insulin Murders about the alarming possibility that somebody might be killed by injection of insulin. It's obviously going to be very difficult to detect, and if there actually is a suspicion that death was a homicide, it should be a police special that's done by a forensic pathologist. The cases that I see are insulin-dependent diabetics who have either accidentally or intentionally taken an overdose of insulin and died. They're often connected to an insulin pump. Usually about the best I can say is that the pump is empty. There is no practical assay for insulin. Also in diabetics, hypoglycemia can lead to what's known as dead in bed syndrome, where they just don't wake up. And this is thought to be due to a catastrophic episode of hypoglycemia during sleep. This is effectively undetectable because of the post-mortem breakdown of glucose. If the glucose is low or 0, you will not be able to decide whether there was hypoglycemia prior to death or whether this is post-mortem artifact. A further thing to remember is that infection increases the requirement for insulin, so deaths can occur in diabetics who have taken their insulin, but who, because they have a concurrent infection, will not have responded in the right way. And I particularly remember a case of a relatively young lady who it turned out had pyelonephritis, and she had taken her insulin, but she'd still died of ketoacidosis because she would have needed to take an increased dose. And one thing she'd done, which I found a bit puzzling at the time, was she was running a bath when she died, and it seemed to me a bit strange that someone who was feeling ill should run a bath. But I was told afterwards by a physiotherapist that not a few diabetics believe that a hot bath lowers your blood sugar, so far from being misleading, the fact that she was running a bath would actually have been a clue. Alcohol is the drug that's involved in death. There are so many deaths related to alcohol that when I collect the data, I have a special little yes-no category for whether or not the death was related to alcohol. It's far and away the most dangerous drug numerically in terms of the numbers of death, the number of deaths associated with it. This leads to an anomaly which I've never been able to understand, that whereas acute alcohol toxicity is an unnatural death, alcoholic liver disease is considered to be a natural death. So if I drink a bottle of whiskey now and drop down dead, I've died an unnatural death. But if I drink a bottle every day and die in 20 years' time of cirrhosis, I've died a natural death. As the Americans say, go figure. Alcohol can be measured in blood, it can be measured in urine, it can be measured in vitreous, if you like. It's relatively easy to measure. The measurements are not that reliable. It does go up a bit after death. It doesn't matter that much. It's the general area, general ballpark in which the figure falls that's important. The legal limit for driving in England and Wales, but not Scotland, is 80 milligrams of alcohol per 100 millilitres of blood, which is a couple of glasses of wine, more or less. So as a rule of thumb, if the subject has 100 milligrams of alcohol per 100 millilitres, it's probably noticeable that they've been drinking, but you probably wouldn't describe them as drunk. If they have 200 milligrams per 100 mils, then they were probably obviously drunk and maybe falling over. If they had 300, they were probably unconscious, and if they had 400, then they could have died. That all sounds very simple, but of course habitual drinkers can tolerate much higher alcohol concentrations, and there are people who've been stopped while driving who've had alcohol concentrations well over 400. This means that it can be quite difficult to determine whether or not alcohol was a factor in death. In general, acute alcohol toxicity is not a common cause of death. Now, that does not mean that you should not give it as a cause of death, but it does mean that the fact that someone was intoxicated does not mean that that is why they died. And before, we were all confined to house arrest by a totalitarian government if you were foolish enough to go out into London on Saturday night. It was absolutely crammed with people who were intoxicated, and they fell over and lay in the street for a while, but by Sunday morning almost all of them had got up again and made their way home. So you should be reluctant to ascribe death to acute alcohol toxicity, particularly in someone who's an habitual drinker. Acute alcohol toxicity, in my experience, tends to occur in people who perhaps are not that used to drinking a lot of alcohol and who are deliberately forcing themselves to drink more than they naturally would. So drinking shots, or if somebody's drink's been spiked, or if someone is just desperately unhappy and they decide to down a whole bottle of spirits, those are the likely scenarios, whereas people who drink because they like drinking will generally just lose consciousness. So consider the circumstances. In my opinion, there is little to be gained if people have a clear morphological cause of death in showing that someone who was known to be an alcoholic contains alcohol. They probably will do, but that probably was not their cause of death. So if they have alcohol-related liver disease or dilated cardiomyopathy, that would be my preferred cause of death rather than alcohol toxicity. Concentrations in urine are generally about a third higher than in blood, and by comparing the two you can make some comments on the timing of when alcohol was ingested. This is only really useful in medico-legal cases like road traffic collisions and so on, and it is not necessary for general coronial pathology. Alcoholic ketoacidosis, which we mentioned, may follow abstinence from alcohol, and fatty liver disease is a good cause of arrhythmias. Unless there is a clear history of alcohol abuse, I would generally, as a cause of death, just put fatty liver disease, and in the discussion I'd comment that it is of undetermined cause. The mere fact that someone's been drinking alcohol when they died with fatty liver disease does not mean they were an alcoholic, and again, in my experience, you will just run into opposition from their family who will deny that they were regular drinkers. So there's no point in speculating on the cause of that fatty liver unless you have some evidence in the history to substantiate your theory. Recreational drugs. I am constantly surprised with just how many people seem to be taking recreational drugs, and that is based on them turning up in tox screens even when I'm not particularly looking for them. As I said, it's not possible to screen everybody, so consider the history, consider the scene and the external appearances. One caveat is that just because there were drugs or drug paraphernalia at the scene does not mean that death was due to a drug overdose. I often get death reports that say there was a large quantity of alcohol or a large quantity of spirits at the scene. Well, that doesn't really signify anything. I'm happy to report there is a large quantity of alcohol here in Convent House, but that doesn't mean if I'm found dead it's because I've been drinking it all in one go. And I've discovered from experience that despite being surrounded by drug paraphernalia, the subject often doesn't actually contain any drugs himself. So if you don't have a cause of death, if you suspect drug overdose, also take histology, because it may well be that this is a natural death unrelated to the fact that the deceased happened to have drugs in the house. Opiates are a major cause of death amongst recreational drugs. Even more so than alcohol, it's important to consider tolerance. It's quite difficult to give a cut-off point for a fatal dose of morphine. Anything above about 0.2 micrograms per milliliter might be fatal, but someone who's habituated to morphine could tolerate considerably more than that. Somebody who has chronic obstructive pulmonary disease could die of respiratory depression at a lower dose, so it's important to consider all of the circumstances. When you formulate your conclusion, all you can do is to consider the natural disease that was present, consider the concentration of morphine, consider the deceased's exposure to opiates, were they prescribed them, were they known to be opiate dependent, and then come to a judgment on whether you think that opiate use was the primary cause of death, or whether you think this is just someone who was opiate addicted who died of something else because they're often quite unhealthy people. In those cases, you can put opiate dependency in part 2. Cocaine. Cocaine use is associated with arrhythmias, and people can and do die suddenly, immediately, or very shortly after taking cocaine. These circumstances are very important here and often won't be apparent. In the laboratories I deal with, even in blood, cocaine comes back as either positive or negative, so it's not a quantitative assay, and you again will have to decide from the circumstances, from whether or not there's another plausible cause of death, whether or not you think that acute cocaine toxicity was the primary cause of death. Chronic use can accelerate coronary artery disease by causing thickening of the arterial walls, and it causes left ventricular hypertrophy, among lots of other things. Apart from taking hair samples, which is uncommon, there's no way of differentiating from a blood test whether someone was an habitual user of cocaine or whether this was the only time they tried it. So I'm reluctant to ascribe heart disease to chronic cocaine use unless there's actually a history. In the lab that I use, there is a special box on the form to tick if I want them to screen for cannabinoids, and I quite often do tick the box because I just go down: opiates, yes; amphetamines, yes; cannabinoids, yes, why not? Cannabis is not a potential cause of death. I would not recommend trying to offer it as a cause of death. Yes, there are a few reports of people who have died of acute cardiac arrhythmias whilst smoking cannabis. I think it's probably coincidence. You can die of acute cardiac arrhythmias while watching television or even YouTube videos, but it doesn't mean it's causal, and I think in the case of cannabis it doesn't belong as a cause of death. It may be useful if you want to suggest that somebody's consciousness was impaired. In, I think it was 2019, the government made almost all psychoactive substances illegal. Prior to that, specific substances were illegal, and so manufacturers invented variants of cannabinoids and psychoactive substances that were so-called legal highs because no one had got round to banning them, and the government responded to that by just banning everything, apart from tea and coffee apparently. And these so-called legal highs were actually quite dangerous. Ironically, because cannabis was illegal, the legal highs were way more dangerous than the illegal drug that they were intended to replace. But for some reason, I think they're still about, and they are associated with death because you simply do not know what is in them. And on the packet, it sometimes says not intended for human consumption, which is, I think, just to as a legal loophole if anything happens to anybody. But if the packet is present at the scene, then send the packet to the tox lab as well, which may help them to do the analysis. Just so you know, because as a pathologist I'm obviously slightly obsessive, I'm pedantic, and opiates, opioids, they are not the same thing. Opiates are things that either are or could be derived from the opium poppy, whereas opioids are synthetic stuff. So please use the right terminology. Fentanyl is, in my experience, an increasingly common cause of death. It's a synthetic opioid, but it really does kill, and I think it's perhaps because it's perceived as being safer. Taking fentanyl may not sound as bad as taking opium, but it's responsible for almost as many deaths. Finally, your role as the pathologist is to interpret the results. You have the results of your autopsy examination. If you couldn't give a cause of death on the basis of morphology, you've probably also taken histology, you've taken toxicology. You now have to put the whole thing together to produce the most likely cause of death. If you wish, you can combine drugs with natural disease. So 1A, chronic obstructive pulmonary disease, and opiate toxicity. It's still an unnatural death. If you don't think that drugs contributed to death, that is, that they directly caused death, that they hastened death, then they don't belong in the cause of death, but you might make a comment in the report to that effect. In the case of traumatic deaths, it's appropriate to make a comment that you think at the time of death the subject was under the influence of drugs or alcohol. The toxicology report may be long and complex. The coroner already has it. If the case goes to inquest, the toxicology report will be put in the bundle of papers separately. So you do not have to reproduce the toxicology report in your report. You do have to refer to it, and if there is a toxicology report, there's always a paragraph in my report that directs the reader to read it. You can summarize the report. Your job is to interpret it. What do you think the significance of the findings was? If, however, the toxicology report does show any drug at a level that could have caused death, then it is incumbent on you to mention that and to comment on it. For example, even if someone had a blood alcohol level over 400, which could cause death, if you found evidence of acute coronary thrombosis and you are satisfied that that is the cause of death, then you've dismissed the alternative, but you have to show that you have considered the alternative. You cannot simply paper over the presence of drugs in the examination. If young people die of left ventricular hypertrophy and there's a history of cocaine use, you may put it in part 2. On a number of occasions I'm a bit suspicious, but without any real evidence I don't think it belongs there, because people will simply say that you don't have anything to substantiate your claim. If, as is often the case, someone has taken multiple drugs, then multi-drug toxicity is acceptable for 1A, but list the drugs, or at least the principal drugs that they have taken at inquest or in an examination, if you have to comment on toxicological findings. Nobody expects you to be a toxicologist. Nobody expects you to be an expert in pharmacokinetics. You're supposed to give your opinion to the best of your ability. And often in court you will find yourself the only doctor there, so you are their source of advice on this. You may feel a little bit out of your depth. You may feel that you can't possibly say exactly how long before death the drug was taken or exactly how much was taken, but you can give a reasonable opinion based on your experience. So, fatal levels of drugs. The toxicology report you get should include an indication of the fatal level. If it doesn't, then you're just going to have to look it up on the internet or in a reference book and say that's where you got it from. You might find a number of different fatal levels. You have no way of knowing which one is accurate, but because assays differ from lab to lab, a competent lab should itself give an indication of the level above which they would expect fatalities to occur. The fact that they have done so does not mean you need to take things absolutely literally. So if we go back to 0.2 micrograms per milliliter for morphine, for example, that does not mean that if they have 0.19, they can't have died of a morphine overdose, and if they have 0.21, they must have died of it. These are biological systems. There's a lot of variability. There's variation in tolerance. There's variation from subject to subject, and the assay is never that reliable. As I've said, it varies from which site you take the blood and whether you milk the lower limb to get the blood out. And for many drugs there's post-mortem redistribution, so the concentration can go up after death, and again a good toxicology lab should mention in the report if they think this is a possibility, and it may end up with you feeling a bit bewildered about this. Obviously concentrations that are way over the potentially fatal level are likely to be the cause of death. Concentrations that are roundabout will depend on the other circumstances. Is there another cause of death that seems to be more likely, or is drug toxicity the only thing you're left with? Because if people took drugs and they die, then that is the fatal concentration. This is where the data come from. They come from cases where there's no other cause of death, people have died, and it's deemed that the drug was responsible. In inquests, coroners, witnesses and juries like quantitative data, whereas people often look rather skeptical when I say that I saw something, or this is my interpretation of something. When you show them a piece of paper with figures on it, they are very keen to believe them. I've never had anybody question whether the assays are actually reliable, whether I got a good sample, whether there's biological variation in susceptibility to drugs. People tend to focus on the figures. So it's possible to give undue weight to particular quantitative results. Everything has to be interpreted in context. Look out for clues in the history. Is there a history of depression? Have there been previous attempts at self-harm? And a red flag, in my opinion, is when people are taking opiates for chronic back pain, because that's a typical sign that people really just want some opiates and have found the easiest way to get hold of them. Also, unless there is an obvious morphological cause of death that is not related to drug toxicity, anyone with self-harm marks, I think, ought to have toxicology, because they've already shown it as suggestive history, and sadly they will often go on to take their own lives. I did carry out an autopsy on a person who had a tattoo like this one, and as chemistry was never really my strong point, what I did, rather ingeniously I thought, was to copy the formula onto the tox form and say, I don't know what this is, but he's got a tattoo of it, so please test for it. But it turned out to be serotonin, so I'm afraid it obviously didn't make him happy. From Essex, Goodbye.